Welcome to the Oregon Bioethics and Humanities Colloquium. Our presentation today, A Life Worth Sustaining, Bestowed Worth, and the Meaningfulness of Continuing Life-Sustaining Treatments in Pediatric Care, presented by Dr. Daniel Kim. My name is Cliff Coleman. I'm here with the OHSU Center for Ethics in Healthcare, and I co-chair this series with Dave Hoyt, who's also with us today. And today's talk actually concludes our 2025-2026 Oregon Bioethics and Humanities Colloquium series. We call it OBHC, and this is a 7-part endowed speakers series that tackles complex issues of critical questions in bioethics and the medical humanities. I'm especially delighted to introduce our presenter today. Dr. Daniel Kim is an associate professor and the new Madeline Brill Nelson Chair in Ethics and Education at the OHSU Center for Ethics in Healthcare. Welcome, Dr. Kim. He has a PhD in religious ethics from the University of Chicago and a Master's of Public Health in Social and Behavioral Sciences from Yale University. He was a 2021-2022 fellow at the McLean Center for Clinical Medical Ethics at the University of Chicago. And prior to joining the center here at OHSU, Dr. Kim was an associate professor at the Alden March Bioethics Institute at Albany Medical College, where he directed the ethics course for clinical students, taught clinical and public health ethics in graduate studies program, and served as a clinical ethics consultant. His research examines ethical issues in healthcare by attending to basic questions of self, community, and culture. He is published widely in leading journals of bioethics, medical education, medicine, and public health, and serves on the editorial board for the Journal of Intensive Care Medicine. Please join me in warmly welcoming Dr. Kim to Portland, to Oregon, to OHSU, and to our OBHC community.
Thank you so much, Cliff. I'm so excited. Thank you for inviting me to give this talk. And thanks, Dave, for all of your help getting us set up. And thank you, everyone, for being here, making time during a Friday to join me for this talk. I'm really excited to be in Portland. This is my second week, the end of my second week, and it's been wonderful meeting some wonderful people. And really, really excited to meet many of you and collaborate moving forward. And I hope this talk is thought-provoking and useful in some way. So I'm really excited to give it. So this is a talk that based on this paper that I published in the spring in the Hastings Center report with my co-author, Xiang Yu. So Xiang is an assistant professor at UTMB in Galveston, Texas. So I want to acknowledge her and note that many of the ideas I'm discussing here I co-developed with her. So she was a clinical ethics fellow at Albany Med, and I was a clinical ethics consultant at the time. Now, the impetus for writing this paper was a case. So let me start there. Right. So baby Y is a 6-month-old who became cyanotic in the context of cardiac arrest, suffering severe hypoxic brain injury, and is now dependent on a tracheostomy, ventilator, and feeding tube to sustain his life. He's not brain dead, but he's neurologically devastated and with only minimal brain activity. In the best case scenario, his physicians expect him to develop severe cerebral palsy, to require lifelong dependence on others for activities of daily living, and to have a reduced lifespan with no ability to communicate. But he's much more likely, actually, to die, despite all intensive medical interventions. Currently, he's not tolerating feeds well, his renal function is failing, and the high vent settings have caused pulmonary trauma. Still, after 3 months of increasing levels of support, his mother wishes to continue life-sustaining measures, citing her hope in a miracle. So this is a highly morally distressing for the clinicians who are being asked to carry out the measures, right? The situation is also all too common in pediatric ICUs across the country. And the worry is that by pursuing these potentially non-beneficial treatments, we may be harming these children in some way. So the ethical question is, should we be doing that? Now, in terms of our recommendation as an ethics service at the time, we were consistent with what later proved to be the recommendation from the American Academy of Pediatrics, which was published in April this year. And actually, one of our very own, Dr. Bob McCauley, was one of the bioethics committee members and an author of this report. So the report makes a crucial distinction between physiologically futile versus potentially non-beneficial treatment. So in cases like baby Y, if the goal is to keep him alive and life-sustaining treatments simply can't do that, then it would be physiologically futile and treatments should be discontinued. Right? But this is rare, right? And it wasn't the case for baby Y. In most cases, a child can be kept alive and their pain can, often be well controlled, including with sedation. So it's often very difficult to say that life-sustaining treatments are definitely non-beneficial, right? The potential for benefit may be uncertain or unlikely, or we may disagree about whether staying alive is in fact in baby Y's interest in this case. But that's not the same as saying that the life-sustaining treatments are not keeping him alive or insisting that staying alive is an inappropriate goal. So our recommendation for baby Y was that, if one, we can't reach a resolution with the parents despite our very best efforts, which was the case, and two, there's no significant risk of harm to him, then it's permissible for the team to continue life-sustaining measures. But of course, in many cases like this, for the nurses, case managers, physicians, trainees, and ethics consultants, the moral distress often lingers, right? We understand the recommendation, but our question is why, right? Why must we put this child through these aggressive treatments? What are we really serving here? Are we really serving the child as we should be? Right? And these are challenging questions to struggle with. And Xiang and I wanted to approach this challenge squarely from the clinician's perspective, because ultimately they're the ones who have to carry out these treatments. So we try to formulate the clinician's questions as follows. One, how am I not participating in using this child as a mere means to assuage his mother? Right? And relatedly, perhaps more ambitiously, the question is, are my efforts to sustain this child's life truly meaningful, right? Is his life really worth sustaining? And if so, how? So in this talk, we'll try to work toward an answer on these questions. So here's the agenda for that. I'll first discuss some difficulties with the best interest standard in cases like this, because as many of you know, the standard is a crucial one in pediatric care. And then second, I'll describe the relational potential standards, which have been proposed in leading bioethics journals recently, and I'll consider a critique of them as well. The critique will then set us up for the proposal from Xiang and me. So I'll introduce the concept of bestowed worth, and building on that, fourthly, I'll argue for the meaningfulness standard, right? Then finally, I'll sum up the argument by showing what we gain with this standard and consider some potential objections to it as well. So we have a lot to cover. So quickly, let me start with the difficulty with the best interest standard, or BIS. The BIS was formalized as an ethical standard in 1983 by the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research. So you can see the report here, and it's titled Deciding to Forgo Life-Sustaining Treatments. And basically, the Commission says that in decisions to forgo life-sustaining treatments, the best interest of the child should prevail. Right? The Commission didn't say too much about what those interests are, but they said that we should consider them from the child's perspective rather than assuming too much about the child's quality of life based on our sort of biased projections as able-bodied adults. Right? So the risk of discriminating against these children based on their disability was a major concern for the Commission. And as it turns out, I think they largely support the AAAP's recommendations that I mentioned earlier. Right? The Commission says that if continuing life-sustaining treatments wouldn't benefit the child's interests, then we should forgo them. But where those interests are uncertain or in question, the Commission allows that if there's no suffering for the child and the parents insist on continuing life-sustaining treatments, then those treatments can continue for a short time. The commission didn't specify what counts as a short time, right? Or why it should be only for a short time. But I think that's understandable, right? It's very challenging. But what it does mean is that we're still struggling with the challenge in cases like baby Y. So that was 1983. And in 1984, John Eris published a critique of the best interest standard, right? So Eris argued that in practice, the best interest standard tends to default to an indiscriminate mandate to treat. And that's because the BIS can't answer the key question in cases like baby Y, which is, is it in his best interest to die or to live, right? Eris asks us to imagine the scenario from the child's perspective, which is what the commission recommended, right? So, quote, the child suffers no pain. He lies there in his crib, blind, deaf, and uncomprehending. Never having experienced the satisfaction of normalcy, the infant is neither horrified by his plight nor depressed by the thought of his impending doom. He just lies there. So does baby Y have an interest in living or dying? One way or the other, right? And Eris's point is that the BIS can't answer this question for us, right? It's silent on this question. And like many of us today, he worries that because of that silence, the BIS risks allowing us to simply use the child as a means to benefit parental interests rather than the child's. So instead, Eris wants us to ask the following question, right? Does baby Y have a life worth living? It's an uncomfortable question because it asks us to make a judgment about what kind of life is worth living, right? But Eris's point is that the question can't be avoided, right? We often try to avoid it by focusing on who should decide. It should be the parent, the physicians, the ethicist, or the courts. But as Eris rightly notes, this move only begs the question, right? Whoever decides, they have to ask this question, right? At what point is baby Y's life not worth living? And we also can't avoid the question by saying we shouldn't discriminate based on quality of life judgments, right? That's because these judgments aren't based on morally irrelevant factors. If we decided based on the child's race or gender or religion, then it would be discriminatory, right? But quality of life is morally relevant to deciding whether a person should live or die, right? We expect people with decisional capacity, for example, to weigh their quality of life when making a decision to forego life-sustaining treatments, and we'd likely deem them to lack capacity if they were unable to do that. So, should baby Y be kept alive, right? Is his life worth living? And Eris's answer is that he shouldn't be kept alive. And Eris makes that call based on the relational potential standard, or RPS. So RPS didn't ultimately become the ethical standard for us, but in recent years, it's been sort of revisited in two leading bioethics journals, the Hastings Center Report and the Journal of Medical Ethics. So there are two versions of RPS. So Eris represents one of them, but the newer formulations of it are quite different and lead to different conclusions. So Eris's RPS locates meaning in the child's potential capacity to relate to others. And basically, he argues that relationships are fundamental to a life worth living. So in baby Y's case, since he's in a situation where no treatments can enable him to relate to his mom or benefit from that relationship, we should stop treating him to keep him alive. Now, the more recent versions locate meaning not in the child's capacity, but in the parent-child relationship itself. So this is Whiteman et al. And Kingsley et al. And they argue that a child in a caring relationship is already a participant in it. So they contend that a caring relationship can be inherently valuable for the child and that we can treat the child to preserve the parent-child relationship. But both of these proposals have their problems, and this is something that my colleague Pierce Randall at Albany Med was arguing, and he has a two-pronged critique. So against Eris's RPS, Randall argues that it risks collapsing into the best interest standard. So when Era says that life is worth living if the child has the potential capacity for relationships, he presumes that this is because those relationships are fundamental to our interests as human beings. So Randall's point is that we can account for the value of relationships in terms of the child's best interest, right? We don't need a separate RPS standard. And then against Whiteman et al. And Kingsley et al.'s RPS, Randall argues that it violates an exclusionary criterion. So in other words, it violates a crucial presumption that we widely treasure in healthcare today, which is, we believe that medical decisions should be made solely for the patient's sake and not to benefit the family, the clinicians, or society. Right? So Randall argues that continuing life-sustaining treatments for a child to preserve a relationship that the child doesn't necessarily benefit from, well, that would violate this criterion. And to that extent, he says that it's morally unappealing. So I'd argue that Randall's critique of the two formulations of the RPS is quite persuasive. So then the question is, should we default back to the BIS? And this is what Randall basically recommends. But Xiang and I find that this too is problematic, right? Because again, the BIS offers no guidance, and defaulting back to it would leave us where we started and with Eris's concerns. And also, we think the BIS actually undersells the significance of the parent-child relationship, which the RPS is trying to explain, right? If a child like baby Y can't take pleasure in their parent's company or desire it, then the child can't possibly have an interest in that relationship. So in that sense, the BIS can't easily explain why that relationship is so important, and that seems incongruent with our practices of deferring to parents with these intimate decisions. So we can't just default back to the BIS, and the RPS is also problematic. So this finally brings me to the concept of bestowed worth. And this lies at the heart of our alternative sort of meaningfulness standard. So let me describe this concept. Now, the idea of bestowed worth comes from Nicholas Wolterstorff in his book, Justice, Rights, and Wrongs. So he uses the concept as a way to ground human worth or human dignity. And now for the sake of time, I won't go there right now, but I just want you to be aware of this larger context. Now, for our purposes, the claim comes down to the idea that being loved bestows worth on a child. Now, not any kind of love will do this, right? Only love as attachment does this, and this is different from love as attraction or love as benevolence. Right, so a Rembrandt painting is beautiful and it's attractive to you, right? But it already has a worth that you love in it, right? You being attracted to it doesn't necessarily bestow more worth to it. Now, with benevolence, if you feed an emaciated pet, for example, so that it becomes more plump and cuter in that way, you've given it a different kind of worth. But what gives it worth is the change that you brought about by feeding it, not your love per se. So a stranger could feed the dog and give it the same worth. Therefore, Wolterstorff says only love as attachment bestows worth. So to the whole world, baby Y may look sickly and burdensome, but to his parent, none of that matters, right? He's loved unconditionally. The parent is attached to the child, come what may, regardless of how beautiful or useful he is or isn't, right? And this is the kind of love that bestows worth. Now, another key point is that the worth this love bestows becomes inherent to the person, right? So baby Y has a distinctive worth as someone who's unconditionally beloved by his mother. It's part of baby Y's identity, right? He's a being of this sort. So this is his worth that we're talking about. So how does this happen? Right? Wolterstorff doesn't provide an elaborate account of how this works. Right? He acknowledges that it's mysterious to some extent. But he argues that the phenomenon is common and readily recognizable. So consider my son's Pikachu stuffed toy, right? Pictured here. This Pikachu has a distinctive worth. So my son spent $95 of his precious allowance to buy it when he was 10 years old. And he did it over my objection, right? I don't want him spending close to $100 on a stuffed toy. But likely because of that, he loves it, right? Even 4 years later, he's now 14, he yells at his sister if she ever touches it, right? He's very protective. This Pikachu is beloved in the mode of attachment, right? My son loves it, not necessarily because it's more beautiful or expensive than other Pikachus. It's older now as well, but simply because it's his and he's attached to it. Now, according to Wolterstorff, my son's love as attachment here bestows a distinctive worth on this Pikachu and sets it apart from other Pikachu stuffed toys, right? If my son were to die today, I may over time throw out his many other stuffed toys, right? But I'll never probably throw away this one because it has that distinctive worth, right? To be sure, this Pikachu is a thing and not a person like Baby Y. So I can't wrong the Pikachu per se. So if I were to, thoughtlessly throw it in the trash, I'd be demeaning my son's memory, but not the Pikachu itself. But there are other cases where we recognize the worth that a person has by being beloved. Right? The example Wolterstorff gives is a person who's beloved by the queen and acquires a distinctive worth as a friend of the queen. Now, that may be a little bit too monarchical for us here in the US, so let me offer a more mundane example. So imagine again my 14-year-old son. His name is Jin, and he's our beloved son, the son of Mr. and Mrs. Kim. Right? We love him in the mode of attachment. He's ours in a way that other boys are not, and simply for that reason and for no other reason, we dote on him. And it's obvious to all that he's deeply loved. Right? Our love imparts to him a distinctive worth. Moreover, Wolterstorff would argue that this distinctive worth is real, insofar as recognizable in at least two ways. One, he can be a source of other people's envy, right? Another person whose parents have died or whose parents don't love them in the same way might say that Jin is lucky to be loved this way, right? And the second, Jin would be offended if his worth as our beloved child were demeaned, right? If his classmate were to dismissively say, big deal, right? And mock our love for him or say that he's not in fact loved, he'd be offended, right? He'd say, take that back, right? Now, I want to believe that he'd be insulted on our behalf as well, and that may be part of it. But much of his indignation would also be because he feels directly demeaned, right? The classmate is demeaning who he is, the worth of his identity as a beloved child of his particular parents. So returning to Baby Y, our claim is that his mom's love for him in the mode of attachment imparts distinctive worth to his life, right? The bestowal has nothing to do with how cute or useful he is to anyone. Right? He's neurologically devastated and he doesn't actively contribute anything to the relationship. He just lies there, right? Yet the fact that he's beloved by his mother gives him a distinctive significance, which can entail differential treatment. Now, if the worth of his life is one that should be prolonged, then not providing treatment would be to disrespect who he is. So I want to note that his mom's love for him is not the only source of his worth. Right? That's not what Xiang and I are claiming. I can mention two other sources, for example. So one is that Baby Y has a basic worth as a human being. So whether he's loved by his parents or not, or even has a parent, has no bearing on his invaluable worth as a human being. Another source of his worth would be his interests and capacities. Right? If Baby Y had potential for human rationality or relationality, we'd rightly feel that we're required to continue life-sustaining treatments for him. But of course, he lacks any such interests or capacities. And in that case, our claim is that his mom's love for him can be an additional source of his distinctive worth as a particular child. In other words, Baby Y's distinctive worth can have several sources, but crucially, the worth we're talking about is his. So our ethical duty is to try to treat him so as to respect the distinctive worth of his life and no one else's. Right? So if we continue to treat him, we're not doing it because he has an interest in it or he has a relational potential, right? Because he has neither of these things. Rather, we can understand the continued treatment as what his distinctive worth demands as a beloved child of his particular mother. Now, again, our point ultimately is to show that to the extent that our love imparts to him a distinctive worth, such that the worth is his, we're not using him as a means. We're trying to respect the worth of the life that he has, who he is as a particular child. Now, with this concept of bestowed worth, we get to the meaningfulness standard. Now, before I launch into this, let me briefly recall the two clinician questions that I opened with. So far, I've used this idea of bestowed worth to answer the first question, right? It offers a way to explain how, at minimum, we're not using the child as a mere means to parental needs or parental ends. But with the meaningfulness standard, we're also after the more ambitious second question, right? Are my efforts to sustain this child's life meaningful? And I think this personal and basic question is increasingly important to clinicians, especially in the setting of moral distress and burnout. So this meaningfulness standard starts from the perspective of this clinician question. Now, by asking about meaning, we're not talking about any notion of ultimate meaning, right? We're not asking what's the meaning of life in some cosmic sense, right? I'm simply appealing to a need that we seem to have as human beings to find some meaning in life, right? In our daily activities, to have something that gets us up in the morning. So this is an issue that the philosopher Susan Wolf tackles very well in this book. So in it, she argues that she argues for what she calls a bipartite view, right? So for my activities to be meaningful, it needs to be both fulfilling and worthwhile. And essentially, she's integrating two common sayings that we have about a fulfilling life. So one is the fulfillment view, right? Quote, it doesn't matter what you do with your life as long as it's something you love, right? And so this is a view I'm sure familiar to all of us, right? And it's highly subjective, right? All that finally matters is that you love it, and there's an emphasis on that. Now, the other view is the larger than oneself view, right? So, quote, in order to live a truly satisfying life, one needs to get involved in something larger than oneself, right? So I was at the orientation for OHSU yesterday, and we watched a video that was talking about just the values of working together, being collaborative, right? Bending toward the light and serving humanity, right? These are all ideas that try to capture something like this larger than oneself view, right? So the activity should have value that others can recognize or appreciate, right? So this serves as a corrective to the fulfillment view, right? And Wolf's point is that if someone were to find their meaning in life, say in carrying Jin's Pikachu toy, right, up and down the stairs all day, every day, most of us would hesitate to say that he's, living a truly meaningful life, because what the person is doing is pointless, right? We're more likely to say that the person is actually deeply deluded if they really do find meaning in it. So Wolf would say that continuing treatments for baby Y can be meaningful for clinicians if it's both fulfilling and worthwhile. So on the one hand, most clinicians presumably find keeping a child alive to be personally fulfilling. But whether doing this is meaningful also crucially depends on whether the child's life is worth keeping alive, right? Whether he should be kept alive. If he should, then the activity would be meaningful, and if not, it would not be meaningful. So here's the key question, right? Is keeping baby Y alive actually worthwhile? So in other words, is the worth real, right? Or is the worth of baby Y's life dependent purely on his mom's subjective whim, no matter how diluted it may be, right? And I would argue that the worth is in fact real, but to get there, we need to sort of thread a needle between two positions. So on the one hand, I'd say that there can't be objective certainty about the valuation of any child's life or how that life should be respected, right? It's a valuation, a judgment that we make as individuals and as a society, whether at the national or global level, right? And the value of sustaining a child's life is not some empirical fact that's out there and that we can observe and measure, right? Rather, the worth of a child's life and what it means to respect it always already involves our interpretation and valuation of it. Having said that, on the other hand, this is not to say that the valuation is subjective all the way down, right? A more clear and precise account of that worth and what it requires of us is possible. So for example, after a few days or weeks, a parent may come to realize that continuing aggressive life-sustaining treatments is not the best way to advocate for him and affirm their child's sort of profound worth, right? And if they come to this realization, parents tend to experience the change as a movement toward a clearer understanding of what their child's worth requires, right? They experience it as a new insight, as a growth, as opposed to a fleeting whim that might go away in the next hour, right? So the growth can also, I would say, go the other way as well, right? The clinician, after some time, may perhaps unexpectedly come to appreciate the profound love of the parent and conclude that the parent perhaps isn't unreasonable to value the child's life in a way that requires treatment. So again, this experience of gaining clarity is something that the philosopher Charles Taylor describes as an experience of moral growth, right? It's a growth toward more clarity about our interpretation or valuation of a phenomenon that matters to us. And I think this growth toward clarity about what the child's worth requires of us happens all the time, right? In fact, we often presume that it should be encouraged, right? For example, when we try to give parents the time and space needed to be at peace with their decision. And crucially, for this sort of moral growth to be possible, we need to posit that the child's life has some objective worth that a parent or clinician can be mistaken about and debate over, right? Even if we can never know for sure if our conclusion is objectively and universally correct, we at least need to presume that the worth of a child's life is not subjective all the way down. Otherwise, our experience of growth itself is an illusion here, right? And we're not actually growing, we're only acting on whim. And I don't think that's how we describe our decisions over this sort of thing, and we wouldn't expect the parent to do that either, right? If they did, we'd probably judge them as very callous and making decisions in a way that actually demeans what's really at stake, the life of a child. So those are my philosophical points, but what does it all mean in practice, if anything, right? So this is where the meaningfulness standard comes in as a potential standard for decision making. So as a decisional standard, Seung and I think the basic question is this, right? Would prolonging baby Y's life serve, one, his interests or capacities, or two, be properly expressive of the worth of his life? So the meaningfulness standard doesn't do away with the BIS, the best interest standard, right? My interests and capacities can indeed make my life worth living. But the point is that a child like baby Y doesn't have any interests in those cases, right? And in those cases, an additional question can be asked. And this is what the concept of bestowed worth adds, right? Is continued treatment properly expressive of the worth of the child's life? If the answer is yes, then the treatment should continue. If the answer is no, then they should stop. So earlier, I talked about growth toward more clarity about the worth of baby Y's life and what it would mean to honor it. Now, in practice, this requires a process of value clarification. So the idea is for clinicians to engage in a process of decision-making in which they're trying to help parents clarify their values rather than merely providing information for the parents to deal with. Right, so this is something that's particularly well worked out in the shared decision-making approach, I think, which John Lantos, for example, has written really well about in this NEJM article. And actually, the American Academy of Pediatrics report that I mentioned at the beginning of my talk recommends actually quite a similar sort of goals-based and value clarification process. Basically, in brief, the idea here is that the goal is to create a safe space, and the clinician's role is to engage the parents in 4 different steps to do that. So one is acknowledge emotions, right? So questions like, how are you doing right now? right? Tell me how you're feeling. And then two, elicit hopes, fears, goals, values. So what are you hoping for? What are your fears? Do you regret anything that's been done? And then third, reflect back the parents' views, right? So what I'm hearing you say is, right? And then lastly, fourthly, move toward a shared decision. So the idea is we face some decisions here rather than you face the decisions, right? So the process may then need to circle back to step one and continue until a shared decision is finally reached. So Xiang and I are not PICU or NICU clinicians, but we think the idea of bestowed worth could prompt the following additional questions at the second step when eliciting parental hopes, fears, goals, and values. Right? So for example, this is your precious beloved child, and we want to respect that. How can we respect who he is? Or how can we help you honor your child's life? So questions like these might be a way to prompt parents to think not necessarily in terms of the child's interests, since the child has none, but in terms of what this child means to the parent and what it would mean for the team to respect who this child is. Right? So some parents, like Baby Y's mom, will decide that honoring who their child is may involve continuing life-sustaining treatments. Other parents may decide that making memories with their child to celebrate their brief life and letting them die in what means letting them die is what it means to honor their worth. Either way, the goal would be to work together to respect the dignity and worth of this child as an end rather than as a means. So to take stock of the argument for the meaningfulness standard, I've now shown that one, it rests on a notion of bestowed worth that's not an abstraction, right? Bestowed worth is something we recognize in our everyday moral experiences. And then second, the meaningfulness standard can operationalize bestowed worth, and it speaks to a need that clinicians have to make sense of their work as meaningful, right? As both personally fulfilling and recognizably worthwhile. Oops. Now, to strengthen this argument, I'd like to point to two further conceptual gains, right? So one is that the meaningfulness standard avoids Randall's two-pronged critique of the RPS, right? The question of what's properly expressive of the worth of a child's life is not an issue just of the child's interest, right? It doesn't reduce to a calculus of the best interest standard because a child can have worth even if she lacks any capacity to realize those interests. And then bestowed worth also doesn't violate the imperative not to use the child as a mere means to preserving the parent-child relationship or other parental ends, right? Instead, it's about respecting the worth of the child who she is as a beloved. The second conceptual gain is that it gives crucial ethical weight and validation to the concerns of people who speak the language of worth, right? Many of you here may recall the case of Jai McMath, right? She was featured in a New York article in 2018. She was a 13-year-old African-American girl who was declared brain dead in California after a routine procedure, right? They removed her tonsils, adenoids, and extra sinus tissue to treat her sleep apnea, but it went horribly wrong. And despite the declaration of death, the parents disputed that she was in fact dead, and they transferred Jahi to a hospital in New Jersey, where they were able to continue treating her for several more years until her heart eventually stopped. Now, I don't necessarily want to get into a debate about brain death here, but I wanted to mention Jahi's case because according to the New Yorker report, what disturbed Jahi's parents was the sense that Jahi was not being treated with respect in accordance with her worth, right? So the family's pastor expressed it this way during a rally they held for the family, right? Quote, "Is not Jahi worthy of the highest amount of medical treatment?" Right? So this valuation has roots in legitimate mistrust and a history and social reality in which Black people in the US have been mistreated by our health systems. But it's also about differing ideas about what it means to treat their child with respect for the distinctive worth that she has as their beloved Black child in this country. Right? So my point is that this language of worth can be powerful for many families, and a concept of bestowed worth can help make sense of it. Now, a counter argument may be that the meaningfulness standard is too permissive, right? When would a parent be wrong about the treatment that the distinctive worth of their child entails? But Xiang and I would argue that the standard actually imposes important constraints and limits. So specifically, decisions that demean the distinctive worth of the child that love bestows would be inappropriate, right? Recall that what bestows worth is love as attachment. So wanton harm would not be loving, right? It would distort that, and it would not bestow worth. So here, the harm principle remains really important. It's important not to be harming the child. Also, decisions motivated primarily by parental self-interest would also not be loving, right? The decision must be grounded in evaluation of the child's worth, not the interests of the parents. Now, of course, it'd be hard to police, right, these self-interested parental decisions in practice. So allowances may need to be made here in terms of its enforcement. But at the minimum, I'd argue that vigilance regarding abuse or neglect, for example, would remain crucial, even within the meaningfulness standard framing. All right, so to conclude, the clinical guidance that a meaningfulness standard, to be sure, they don't lead to necessarily different sort of clinical guidance from the current consensus recommendations. I think we have those recommendations and we have them right. But with moral distress in mind, what we've tried to do is affirm or explain how a clinician's obligation to continue life-sustaining treatments in cases like BabyWise can be meaningful, and why it doesn't entail using the child as a mere means, right? Our hope is that, it enables clinicians to make sense of the worth of the life that they're sustaining, and hence the meaningfulness of their obligations. All right, that's it. So let me stop the presentation, and happy to take questions.
Thank you, Daniel, for that really wonderful talk. So interesting, and I think, gosh, there's so much to digest here. I imagine folks will take a few minutes to probably formulate some questions here. But Saratab has put in a couple of questions for us already. So let me just, I know you can't necessarily see the chat here. Let me just read these for us. So the first question is, could you talk a little bit more about the theories that look beyond the unit of the individual person for worth, for best interest, for decision making, to the unit of the family, and how they help inform this discussion?
Yeah, so I think these questions of worth are very much, and this is right in line with what Charles Taylor is saying, right? It's a question of worth. It's a kind of valuation, right? And even within the history of human rights and its development in the 20th century, I think there is a kind of a development and evolution that can happen, right? Where we're constantly in conversation, and these conversations can happen at a global level. It can happen at a national level. It can happen at a communal level, right? Smaller communities, including the family unit. And so I think we're sort of, even as we sort of think about these questions of worth for ourselves and engaged with our loved ones within families to figure out what we're talking about, I think, yeah, it's really important to remember that there is a valuation component, but at the same time, for that kind of discussion to be to make sense and have any kind of importance, we have to presume that we're actually debating about something real, right? That there is a real worth that we're trying to get a better handle on and come to a better understanding of. And so I think the family does play really an enormous role in helping shape those conversations for various individuals. And, for a particular, case, particular child, there may be some differences in terms of how those valuations are done. And of course, the societal sort of valuations in terms of human dignity and the basic worth of us as human beings, I think put some important constraints on those familial discussions. But yeah, it's a very sort of dynamic process, I think. That's the way I picture it.
And just following along on that, and as you having your experience as a clinical ethics consultant, I imagine you've had some moments where where that dynamic and that dance between the individual and the loved ones, um, I'm sure is often, if not always, difficult to disentangle.
Yeah,
Um,
for
can
sure.
you comment a little bit more just on some real world experiences around that how that
Yeah.
actually goes in the real world?
Yeah, I think in the real world, it requires a lot of practical wisdom, right? In sort of negotiating that, because I think sometimes these discussions with the family involvement and helping the patient sort of think through, right? So this is not necessarily pediatric cases, but with, for example, adult patients, if they're sort of thinking about whether to forego life-sustaining treatments and the family is involved, right? Sometimes I think it's our role to help support the involvement of the families, right? Because it can be really, really healthy and help the patient sort of think through things. But there, you also get cases where the families have their own agendas and maybe are trying to impose their own ideas, and they sort of cross the line between trying to be persuasive versus being a little bit too aggressive, right? And so I think sometimes there are times where we need to sort of keep the family away, right? Create some separation and give the patient some space in cases like that. So I think there's some practical wisdom and negotiation that's required in those kinds of situations.
Yeah, yeah. There were a couple of comments in the chat about just some difficulty with hearing, and I don't know if
Oh,
some some folks maybe are having trouble hearing and some aren't. I don't know if there's I don't know if there's much that we can do about it. But
okay.
if anyone else is having trouble hearing, just throw a message into the chat so I can try to acknowledge that and see what we can do. Um, while we're while we're waiting on that, well, Dave's comment here is maybe if it's possible that your camera platform is
Hmm.
maybe rattling, perhaps. I'm not sure if it's moving. It doesn't look like it's moving to me, but um,
Yeah. Yeah, my microphone is at its maximum volume, so
okay. All right. If anyone else is having
I
trouble, please just
apologize.
throw a comment in for us so we can see that. Um,
Okay.
so Sarah Taba had a follow-up comment, which I think actually you'll find a question in as well. And it's a bit longer, so let me just read this to it. So she says, so often these cases are a little less, I think crisp is the term, a little less crisp about the certainty that a child will not enjoy any meaningful interactions with their environment.
Yeah.
We just are hard pressed to prognosticate how severely impacted a child will be in this type of scenario. If we start to think, uh, if we start to think of the individual and the individual's family or unit, we can help guide even without being able to accurately answer that question of personal worth, meaningful life. So again, I think it's going back to that individual, family, and that dynamic and having to work with that interplay, I guess, between the two.
Yeah.
Yeah.
Yeah. Yeah, I think so. And I think I for me, like it speaks to the need for a certain degree of humility, right? Yeah, I mean, I think to Sarah's point, especially when we're trying to prognosticate the outcome in terms of just in children, right? Uh, in terms of neurologic outcome, that it can often be challenging, right? And it can be prone to mistakes. And so I think there is a degree of humility that's required. And I think it actually is helpful to remember because it then creates a little bit more of a open space where clinicians and families can sort of engage in each other and engage in that sort of shared decision-making process. So for me, it emphasizes the importance of that sense of humility as well as the importance of this shared decision-making process and thinking of it as a process, right? And so not jumping too quickly into a conflictual sort of mode.
Yeah, yeah.
Yeah.
Um, as I was listening to you, I was, of course, Very excited to know that you're coming in as a new chair in ethics education here at OHSU, and
Yeah.
kind of, and as someone who's involved in that myself, I was really, I'm really curious to kind of use what you're
Mm.
use your thesis here and the way you're thinking about these issues to think about the way we educate
Yeah.
the next generation of healthcare professionals. And I, you know, I, and I'm really highly aware of a lot of the criticisms that we see today around um, people uh, recognizing or noticing the healthcare training process as being relatively dehumanizing, and what we know about what happens to individuals as they pass through this educational process in terms of loss of empathy and some other things. And I wonder how
Yeah.
that will, um, trying to center on someone's worth and to think about that as a person who's also going through this educational acculturation, which maybe is trying to dampen our ability to value others. I wonder how
Yeah.
we're going to deal with that and what your thoughts might be about that.
Yeah. I think really important question, right? I think of worth and this contribution, right? And encouraging us to perhaps think about this notion of worth in cases like this is a way of sort of expanding our moral imagination, right? And I think especially as we become a little bit more aware of the challenges of moral distress, and I think the nursing literature has done an amazing job of developing that over many decades, and increasingly it's been taken up by the medical literature as well. Um, I think one of the and this is why I started with the question of why, right? In the sort of training mode, like if we don't have clear explanations, right, for why we're doing what we're doing and what the recommendations are, and if those explanations are inadequate, I think the trainees are essentially left with a kind of a major question mark. And in terms of you follow the recommendations, and in terms of what that, how you really think about that personally and reflect on it, you end up sort of drawing a blank and perhaps, brushing it under the rug and moving on, right? Because we have busy lives. And the concern, at least from a moral distress perspective, is that, these distressing experiences over time can accumulate and cause more problems down the road, potentially burnout, right? And so I think within a sort of thinking about medical education, this is why I'm a fan of sort of thinking about ethics and kind of moral formation and thinking of it as a kind of longitudinal process, right? Where we help trainees and walk alongside them in order to and create spaces for them where they're and facilitate their reflections, right? And think about and ask these and encourage them to ask these why questions. And I think part of the role of ethics is to be a resource and provide adequate explanations for some of these challenges that they're facing on the ground. And so that's how I sort of think about the role of ethics. And I think what I'm talking about here has certainly some implications for how we think about medical education. And yeah, finding adequate time and spaces within the curriculum, I think, is another set of challenges, but that's at least the idea.
Yeah, 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 yeah. I don't know that it's been studied, but it sounds like maybe it should be that just asking these questions about identifying worth and thinking about how to address very thorny questions like or cases like baby Y's.
Yeah.
Um, I'd be very curious to know like kind of what outcomes that has for experiences of moral injury or moral distress, or burnout and others. And if has that been looked at? Are you aware of any of that?
Yeah, no, I'm not aware of any of that, those kinds of studies. Yeah, a lot of the sort of studies looking at how we mitigate moral distress really focuses on sort of some of the institutional constraints, improve culture of communication, and things like that. But just in terms of, but we do know that these ethical dilemmas and really hard ethical cases can be a source of moral distress. And yeah, it would be interesting to sort of explore whether creating more spaces for ethical conversations, facilitated discussions, where at least there's more clarity about the rightness or the wrongness about what we're doing, because moral distress is rooted in a feeling that you're doing something wrong. And so if we can clarify in what sense what you're doing is or isn't wrong, right? At least in theory, it should help to some degree. And I think the challenge is trying to measure it in some way.
Yeah.
Yeah.
All right. I guess I need to apologize. I think that we discovered the problem with the sound was that I was not muted during discussion. So I apologize for that. And thank you for one of our attendees for pointing that out to me. All right. Well, we're coming down to the last few minutes. And if anyone else has any other comments or questions they'd like to put in the chat, we certainly like to see those. I want to just take this moment to ask you, Daniel, if you have any other parting thoughts that you'd like to share with us today, or thoughts about your any other thoughts about your joining us here and what we should be doing to help partner with you.
Yeah, thanks, Cliff. Yeah, I mean, I had a blast giving this talk and engaging everybody's questions here. I'll just say I'm just really grateful to be here and for the opportunity. I think this talk is sort of representative and illustrative of the kind of work that I hope to do at OHSU, where I think the role of ethics is to help us think critically about some of the assumptions that we make, right, in our moral lives. And our moral lives can be at the institutional level, it can be at the personal, reflective level, at the interpersonal level. And so I think the role of ethics is really to help us sort of think critically about some of those moral assumptions. And so I hope I tried to do that in this talk, and it's at least the kind of work that I hope our ethics center can do more of and continue to build on that kind of work that it's been doing. And yeah, I'm just really, and I think it requires these ideas, especially if we're going to innovate around some of these ideas. I think it requires conversation, it requires discussions, it requires hearing, and it requires interdisciplinary conversations, right? And hearing different perspectives from different professionals and different folks. And so I really, I think it kind of these interprofessional and disciplinary conversations, I think, are at the heart of what it means to do ethics and to do good ethics. So I'm really looking forward to just working in that sort of interdisciplinary and collaborative manner, and really, really excited. Looking forward, yeah.
Well, we're really excited too. So thank you for those comments. Thanks for a great talk. Thanks for really ending our OBHC series on a really strong talk and note. And I think that sends us off with lots to think about. There are a bunch of great kudos coming into the chat here. People appreciating you, so that's nice.
Thank you so much.
And I want to take a quick moment to thank Dave Hoyt for a great season. Thank you, Dave. It's great partnering with you on this. I want to thank all of our attendees for joining throughout the year, and your engagement and contributions have been much appreciated. As always, a reminder, Dr. Kim's talk has been recorded, will be posted on our OBHC website for you or for others who you may know who didn't get a chance to join us today to take a look at that. I want to remind us that OBHC will start up again this coming fall, and that I'm absolutely delighted to share that our very own Dr. Daniel Kim, who's our presenter today, now as the new Madeline Brill Nelson Chair in Ethics Education at the OHSU Center for Ethics and Healthcare, will be taking over as chair of this series. And so I couldn't be in better hands. I'm very excited to see how the series evolves under your leadership. And I hope to see you all there this fall. Have a great summer, everyone. Thanks for being here.
Looking forward to it. Thank you so much.